So my name is Lisa Hirschhorn. I use she and her pronouns. I am professor of medical social sciences and psychiatry and behavioral health at Feinberg School of Medicine at Northwestern University. I'm giving this talk is I actually started off my career as an HIV primary care provider working in FQHC in Boston. And I was really intrigued by the fact that I was working at a hospital up the street, and then I was working at my FQHC, and the gap between what people had access to and what people were getting, and this was really very early in the days of even just, prophylaxis, was huge. And really sort of recognizing that quality was very important. And over the years, I think HRSA has really been a huge lead in terms of pushing quality, something that's lagged behind in some of the other work that I've done around that. And so what I'm going to do is talk about quality management and quality improvement, the best practices for your organization. This is often done as an entire week. And so this is just 90 minutes. And so it's really just to give you an idea of some of the concepts and then leading into where the center can actually help. But as a primary care provider, an HIV physician, and as somebody who largely does these trainings in terms of clinical and social services, I apologize in advance that some of the, you'll see a lot of the examples are more clinical. And so in apologies in advance to housing and legal and the other components, and I would love to learn from you as well as moving forward. Okay, so the goals for today are to understand how to define quality and measurement in your scope of work, strengthen how to define and communicate the goals of quality improvement, begin to work to identify and address barriers to quality, understand the core ideas of quality management and its relevance to your programs, and finally provide input and identify how the evaluation center can help strengthen your QI and your QM work. So what is quality improvement all about? Oh, trying to get rid of that. So I've spent a lot of time trying to take away the jargon because you can really get people confused. And work that I've done with a number of organizations really sort of down to sort of three key things: defining quality, measuring quality, and then doing something about it, which is quality improvement. So defining quality, we really know what is supposed to be done. If we don't have an idea of what's the right treatment, what's the right process for housing screening, it's very hard to actually measure quality until you understand what it is. The next is knowing if it's being done. So again, measuring quality, what are the metrics that you need to have to be able to know if the services you have are actually meeting your definition of quality. And then very importantly, figuring out what changes are needed if a problem is found, doing it, and then checking to see if it works. And that really is the cycle of quality improvement. Some other key concepts is that it's team-based, and often it is focused on systems as opposed to trying to change individual behavior. So before we get into quality improvement, which I think people probably are more familiar with, what is quality management? And there's a range of different definitions, and I'm sort of really taking some of this from HRSA and from others. And so quality management is often defined as a, quote, planned, systematic, and organizational-wide approach to monitor, analyze, and improve the organizational performance, thereby continually improving the quality of care and services provided. And HRSA defines it as the coordination of activities aimed at improving patient care, health outcomes, and patient satisfaction. So what's also important, as I'm sure you're all aware, is that under the Ryan-White Modernization Act in 2006, actually the HIV/AIDS program recipients are required to establish clinical quality management programs to assess the extent to which HIV health services are consistent with the most recent guidelines. So there we have quality, the guidelines, and measurement. Is it actually being done? Develop strategies for ensuring that such services are consistent with the guidelines, quality improvement, and the idea that this should be ongoing but fit within the structure of the framework of the overall functions. So why do you need a quality management program? Why can't we just do quality improvement projects and sort of address the different issues? And the reason why is we've really found over time that to plan, implement, and sustain improvements in quality, the overall program needs that kind of infrastructure that's both quality assurance and improvement. And that a quality management program supports and improves the quality improvement work that's being done to improve quality. And again, this idea about there's quality management, which has a program, and within that is a plan, which we'll talk about in the next workshop. And I really like this. This is from HIVQUAL, which is now then became NQC and is now under CQII. And the idea is that you have this yin and yang of quality improvement and performance measurement. And then really supporting it is that infrastructure, which is the quality management program. So the idea of this whole program, again, which we'll talk about more next time, is that it should integrate the culture of quality and performance measurement throughout the program. Can't do quality improvement unless people are actually open to saying, there's a challenge, how do we actually get that better? It allows for a more systematic approach to measuring and improving quality, so people are not just doing different things. Ensures that there's a prioritization of quality and a shared understanding of goals. It can include some very important steps that often have to be very carefully thought out and proactive, such as, for example, consumer engagement, as well as the resources for measurement and QI. It helps you develop your QM plan, which is your sort of overall map for the year. And again, it's very important for building program capacity and sustainability for quality improvement. If you sort of look at it within the context of sort of the traditional PDSA cycle, which we'll talk about, Plan, Do, Study, Act, which is the quality improvement project, that's sort of the inner circle. And then again, the HIPQUAL model has this idea of this outer HIV quality program, which is the quality management program. As we know, there'll be, talk more about a quality management plan. I know all of you are required to do that and have indeed written some. Has a quality statement, what's your infrastructure for QI, what are your metrics, what are your goals, how are you getting participation of stakeholders, including your staff and consumers, how are you evaluating whether it's working? And again, we'll talk more about this in the next workshop. So now, unfortunately, the poll, this is one of the Zoom needs to do a little PDSA cycles. We can't actually do a chat, which allows you to write things in. And so what I'd like you to do is in the chat is how do you define quality in your scope? So whether you're doing clinical or housing or legal or mental health, how do you define quality? Just a few words or a sentence.
We've got patient satisfaction. Looks like someone said evidence-based, client-centered, accuracy, outcome, achieving outcomes, accountable, another patient-centered, data-driven, measuring success, methodology. These are all great.
Great. Okay. So these are all really, really important. And it gets at a lot of what we talk about when we define quality. And some of these are how you might define quality, setting and achieving performance outcomes, really good. And some of them is how you're actually going to get there. And so it's a really fabulous list. Okay. Oh, how do I resume share? Here we go. Great. So the Institute of Medicine defines quality of care and health. So again, apologies for the non-direct clinical providers, is the degree to which health services, so you could actually replace health, for individuals and populations, increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So again, there's this idea of what are the standards, what do we know should be done. Oh, it's a bit of a challenge in HIV. I've been working in HIV for 30 years or more, and I can tell you that the current professional knowledge has changed remarkably over time. So some of it is also keeping up to date with what actually is current professional best practices. We can use this for other areas as long as we know the outcomes and professional knowledge. So what works? And sometimes it may not be that well, and then you have to actually define it internally through getting people together and say, okay, how are we going to define this concept of quality for which there may not actually be professional standards as yet? Now, a lot of times people have thought about quality as simply technical quality. So it's whether or not you are actually using the right medication, doing the right screening, things like that. And that's very important, that technical quality. But the Institute of Medicine and other people, and I was delighted to see that people brought up in this idea of patient-centered, is that there's actually 6 components, and we often measure a lot of the effective ones, but we often don't measure things like patient-centered. But again, we had patient satisfaction. Timeliness, so for example, for rapid start, there's a difference between starting antiretroviral therapy in 6 months versus same day. Efficiency, equity or equitable, as well as safe, which is obviously very important in the COVID era, but has been really important all along, regardless of what you're actually providing. So how do we decide what is quality? Again, The easiest is when we can base it on evidence-based recommendations or guidelines, HRSA, CDPH, CDC. They communicate how care or services are supposed to be delivered. Again, these can change over time. So for example, all people living with HIV should be started on antiretroviral therapy. If I were to pull out this training from 5 years ago, that would not be true. Everyone should wash their hands before and after meeting with someone. That, on the other hand, has been true for 200 years. Still not great at it, but something in which a standard should never change. So why do we care about quality? Is it just because we're going to get dinged from a project officer? Well, we know that gaps in quality lead to bad outcomes and death. It leads to wasted resources. We see this, for example, in antibiotics that are being overused or people who are not getting the right services. And very importantly, it gets to the patient experience, which is poor experiences with services resulting in clients who do not return. And with HIV, that has always been a key component of how we define a quality system. The systems often wish to provide high quality of services, but it's not always achieved. So I don't know of anybody or any organization that says, today I think I'd like to be mediocre. I think I'd like to sort of deliver mediocre care. But there certainly are providers and organizations that say, you know what, we're actually not providing the care we want to provide. It is actually mediocre. And so that's really the emphasis to say it really does require change, because there's a number of different sort of key things, but the bottom line is that all improvement requires change. And we'll talk a little bit about why you need to measure, because not all change results in improvement. So if quality predicts outcomes, the big question, and this is what's really driven a lot of the work I've done over the last decades, is why don't clients get the care and services we know work, and what can we do about it? And that is really the core of the inspiration for me around quality improvement. So what are some of the principles of quality improvement? And again, apologies to those of you who actually could be doing this, leading this workshop. But to just go over it, is that often we achieve continual improvement through small incremental changes. So often it does take these small steps. Occasionally, we can actually achieve faster success. There's one problem, there's known solutions, and everyone agrees. And there's one really fabulous example of this, which is there used to be a big problem of bloodstream infections in people who had inserted what are called central lines, so lines that are put into a big vein in intensive care units, and people would die from these infections. And somebody figured out a bundle, 4 things that you needed to do. And it turned out that if you just did those 4 things, then actually you could get rid of most of the bloodstream infections. Sometimes, however, we do need to change the system. So sometimes the system just is, you can tinker with it all you want, but until you actually make a big change, whether it's in patient flow, whether it's in how people are screened or entering, whether it's in task shifting or task sharing, sometimes we actually need to do bigger changes. Key is we can use ideas from other people, so don't reinvent the wheel. This is different than research where you want to come up with something new every time. You really want to be able to borrow from other people, to adapt it to your situation and to leave. And we call these things bundles or change packages, which are ideas that work. And one of the things that I think we really want to promote among the group of organizations in Chicago is how do you share some of the solutions? And sometimes we just need to work on what we know is right. So even if you haven't been able to measure it, but you know there's a problem, linkage into care, addressing disparities in racism. We want to measure it, but sometimes we just need to make sure that we're doing the right thing. So here's a few more principles. Again, we need to address it through a multidisciplinary team. That success is achieved through meeting the needs of the customers, whether they are the patients, the providers, or the community. And many times we need to address more than one gap. Now, don't try to improve everything at once, and design for sustainability. So I don't know if people know what this image is on the bottom right. If anybody knows, can they put it in the chat? I'll give you a hint. It might be a game that you might play at a carnival or something like that.
Someone said whack-a-mole.
Absolutely, it is indeed whack-a-mole. And so the idea is that if you just focus on one problem, you get it fixed, and you don't actually design for sustainability, the other one's going to pop up, and they're going to go to another one, and that same one's going to pop back up again. And so it's how do you actually prevent your quality improvement from being whack-a-mole? Okay. And the idea is also is that, and this is why we'll talk about quality management, is that QI requires structural support, leadership, and other resources. You can't do QI for free, and you certainly, it's very difficult to do it if your leadership is not supportive of that. So one of the classic things that we talk about is this idea of models for improvement. And it asks these sort of three questions, which is what are we trying to accomplish? So what is the gap and what is our goal? How will we know that a change is an improvement? So how are we going to measure? And then finally, what change can we make that will result in improvement? And that's really your quality improvement project. And a lot of quality improvement work sort of dates back to this model for improvement. So how do you know, the first step, where your program has gaps in quality of care? So the first thing that we need to do is we need to measure. But you can't just measure. So sometimes I've seen programs that are very successful at measuring, and that's success. Success is we know what's happening. But unless you're actually willing to engage in this entire circle of measuring, identifying a gap, and prioritizing it, understanding it, and working to address it, you're just going to have this wonderful measurement system, and it's not going to actually result in improvement. So how do we do that? So again, this idea is that you're identifying where there are gaps. It tells you where to focus your efforts. It allows you to follow progress over time, and then you need to remeasure. Did you make things better or worse? And I have been the designer of quality improvement projects that have made things worse. And it's only because we remeasured that we realized we're headed completely in the wrong direction. So now to measure this, you need SMART indicators. And there's a lot of different definitions for those particular 5 letters. I tend to use specific. So it's asking a very specific question. It's measurable. There's a lot of things we'd like to actually measure that we can't. It's actionable, meaning you can do something about it. It's relevant to your population. And it's time delineated. So it's something within the last 6 months or last year, et cetera. A lot of these are available and some are mandated. So the first thing I always do is go back and say, okay, what is it that I have to measure? And then what are the things that I'm actually missing? One of the things that's been very sort of interesting and exciting for me is I'm a quantitative person. I think about things in numbers. And I've really understood the value over the last 10 years or so of qualitative information. And some of these measures, even though you may say, well, it's not, we can't actually do this by doing a number. Sometimes we do need to just ask people and say, you know, how is this working? Why is this working? Tell me how are we making you feel for that? And then figuring out how to even ask the questions depending on your population. So the one thing which you have to do is sort of the quality of care gap. So this is the difference between the expected and the actual performance, and that's your opportunity. So for example, if you say all people who test positive for HIV should be seen within 72 hours, but in the current system, only 40% of people who test positive for HIV are being seen in the, sorry, typo there, are being seen in the 72 hours, you have a quality gap of 60%. 60% of people are not getting the care that you would like them to get. So where do we look for quality? Donna Bedian, who's one of the sort of fathers of quality improvement, sort of had these ideas of structural quality. So the systems and the resources. What kind of human resources do you have? How are they performing? How well are your systems working for tracking people? The process quality, so often called technical quality. So that's are people actually getting the care we want? And then the outcomes quality, which is sort of the results. Are we actually seeing better viral suppression, better housing rates? The other thing that's important is to understand that there's a very good point in the chat, which I will get to in a minute, is customer-defined quality. So this is what we call experiential quality. And by doing that, it's a little bit different than satisfaction. So this is asking about, like, how long did you wait? Did people explain things to you? Were you treated with respect? Satisfaction says, were you satisfied with the care you got? And the reason why I measure both is satisfaction is when your experience meets your expectations. So if I have very low expectations, if I've always been yelled at and treated rudely, and somebody is in the least little bit respectful to me, I'm going to say it was the best care ever that I ever had. And I'm very, very satisfied. If on the other hand, I'm actually used to a very people-centered clinic and I get just a little bit of respect, I might say, I'm not so satisfied. So we need to actually measure both of those. And then very importantly is what I call the fifth domain, which is equity. And so if we're giving great care to 80% of our clients, but the 20% that are not getting it are the most vulnerable, the most underserved, then we do not have a quality system, and we need to worry about equity as much as we do about the overall gap. So I just want to go back to if I can figure out how to do this, to the chat. So Ishu, do you want to actually say what it is that you wrote there? It's a very, very important point.
Oh, sure. Hi, everyone. So just like I think 2 slides ago when you sort of talked about the SMART qualifications, I guess, it kind of seems like if with QI, you might run the risk of picking and choosing and only addressing things that are easy to measure or things that are easy to act on. So then you end up like not really addressing things that need to be addressed merely because you're not sure how to measure them or because you don't really have a way to act on them.
I could not agree more, and thank you for really bringing that out. I think this is this idea that SMART indicators are what you want to have, but the question is, how do you even define measurable? And it's a little bit harder to address something if we can't measure it at all, and that's why I think some of the qualitative work is important. Sometimes it's from focus groups. I had one provider, this is in another country, who the way that she measured quality was the waiting bench was right outside the window of her office, and she would listen to what patients said. If patients were unhappy, she could tell that, and there's no metric for that. So I agree with you. We have to think a little bit outside the box. So they could still be smart, but measurable may not be quantitatively. On the other hand, I also agree with you that we should sometimes think about quality improvement of things that we could change more easily, but also what are some of our longer term measures. So I will bring up, I think it is really a big issue about issues around sort of structural racism. So we can't fix that by next Tuesday. And actually, if we try to fix it by next Tuesday, it's probably not a good way of doing it. So that sometimes what people will do is you'll choose different gaps, and you'll choose the gaps which are easier to improve, and ones which maybe are bigger are threats to people's well-being, and then longer term ones that also may be threats to people's well-being, but will take a few months. And one of the reasons for starting with some of the easier ones is you get buy-in. So you the concept of sort of low-hanging fruit. So you might want to start on some of those, but also, I completely agree with you, is things that can't be easily done. Now, sometimes you end up with things where you realize are not within the scope of the action of the clinic or of the program, and then you have to figure out how do you actually then figure out how do you bring in the other people who are involved in that type of work. And I think that's a very, very, very important point. I'd like to keep that up, and please call me out if I deviate from that. So again, what do we measure? Again, the systems, things like wait time and staffing, technical aspects of care, percentage of patients getting viral load testing or people getting the housing referrals, the results of care, the patient's experience with care. And then I'd love to maybe, I don't know if we're gonna have time this time, but talk about what's some of the other things that people think we really need to think more closely about how do we measure. And is this an opportunity for this group of organizations to come together to actually push forward some of the way that we measure things that really do matter. So for example, again, and I apologize, this is sort of clinical and very quantitative. I've tried to sort of simplify for this, is that you've decided you want to know whether your clinic is providing good quality of care and testing new HIV patients for TB within a month of diagnosis. So your SMART indicator is the percentage of HIV patients enrolled in the last month, so it's time delineated, who received TB screening within 30 days of their first visit. Pretty specific, measurable, hopefully actionable. It certainly is relevant, and it's time bound. Not so smart is percentage of HIV patients tested for TB. Which HIV patients, over how long, when should they be tested for TB, things like that. So again, it's these details that really help you understand. Now, again, I apologize. This is probably what a lot of people already know about, but I just want to do this, and we will share these slides. So if you want to go back into your clinics and actually do some of this training as well. So again, if you want to measure performance, so your starting population, maybe all new HIV patients seen in the last month. Who's in the denominator? The denominator is the number of patients who should have received that service. So in this case, it would be new HIV patients who don't have active tuberculosis. You shouldn't actually screen for TB if they have active tuberculosis. And then the numerator is who received services. So this says 7 out of 8 of the eligible patients actually got screened for tuberculosis. So this is just sort of a visual for this, which is the population, the denominator, and the numerator. And the only thing is that if everybody's eligible for measurement, so everybody should get a viral load once a year, as an example, then that your denominator becomes everybody who's in your population. So before we dive into what to do about it, this is a very common complaint, and I'm curious if other people have heard this. The data are wrong. So we're actually doing much better than that. It's not just that 50% of our clients are taking their medication, or 70% of our clients are getting cervical cancer screening. It's actually 100%. The data are wrong. So has anybody heard this before? You can just raise your hand. Nobody. I'm impressed. I hear this all the time. So it's very important to explain to people there's sort of two gaps that we talk about, and both of them are a challenge. The first is the data quality gap, and that is actually the data do not accurately reflect the quality being measured. So 90% of people needing mental health services got them, but the data only documented 50%. And the reason it's important for knowing that is because if it really is 90%, the answer is don't do PDSA cycles to increase the number needing mental health services, although it would be nice to get it to 100%. The first thing is fix the data quality. Why is it that it's not being documented? Now that's different than obviously the service quality gap, which is the data reflect the quality, but the quality does not meet the standard. So only 50% of people needing mental health services indeed receive them, in which case then actually you do need to address the service delivery and the systems. Now often it's a combination, and both of those gaps can be targeted by quality improvement. And often the improvement that we see at the beginning of QI projects is often due to data quality. So things which are not being documented. And then when you start telling people we're measuring this, we're feeding this information back to you, a lot of times the data quality can actually get better. But it's always important to sort of put that out and make sure that you actually have confidence in your data and decide where you're going to address first. So now we've sort of gone through measuring quality. And the next thing is obviously identifying the gap. And then so this idea about what do you do with your data? So the idea is, you have to feed back your performance measures to your group, and working as a team to prioritize where to start. Most of the problems, again, are found in processes or systems, not in people. So pointing a figure at somebody is probably not a good idea. And again, to fix this problem, we have to first understand why it exists. And there's a whole sort of method about how you actually feed back data. And you can do it like, wow, we only serve 20% of people. Like, what are you all doing? You're not doing a good job. As opposed to, I'm worried because we're only, meeting 20%. It's kind of like, what are your ideas about how we could do better to do the 80%? So if I did it the first way, most people's reaction usually is, oh, go away. The second one is, how do we actually work together? And that's an area that we can certainly do some additional training in. Not today, we don't have time. I do a whole training about coaching that might help with this. So identifying a gap and prioritizing. So again, you may find 5 or 6 different gaps. And so it's really important that you do have a way that people are going to prioritize and really listening about which one is important and why is it important. And again, you might choose 2, one of which is a longer term one, and one of which is, well, we could probably do a pretty quick fix and then celebrate the fact that we're actually doing QI. So the clinic team meets and they decide that screening and referrals for mental health is a priority. And as a first step, they want to try to improve the screening, because obviously you need to screen to be able to actually refer. And so the question is sort of, what do we do first? Like, we want to do this improvement. So often people get stuck here. And one thing that I found very helpful is that asking 4 simple questions and writing answers can often help make sure everybody's headed in the same direction. And those are, what is the problem? What is the goal? How will you measure it? So it sounds very familiar, right? Model for improvement. And who should be on the QI project team? And then you start all the rest, the flow chart and gap analysis and designing your first quality improvement intervention. So this is an example. Only 25% of people identified as needing mental health services get an appointment within 3 months. So this is the problem. What's your goal? So your aim is to improve the percentage of people receiving a mental health appointment within 3 months to 60% by 4 months. So again, you have a very time delineated aim. You want to go from 25 to 60%, and you want to actually do this not over the next 3 years, but within the next 4 months. How are you going to measure it? And this is where this is different than regular performance measurement, because often with QI, you want just a little taste, like, do we think this is working? And so you can do a quick chart review after a week. So if after a week you've seen 10 patients and you still only have 2 who got referrals, then whatever change you made probably didn't work so well. And then you're going to work to get the report designed for the routine data system. And you've decided that you really want to get a clinic provider, a community mental health provider, the folks in IT, because you're going to ask them to do the data system, and there may be many other people. And I've often found this is very helpful to get people to understand what it is that you're trying to do, and then also communicate it with the rest of the program. Okay, so now we have to understand sort of why the gap exists, and we already have some people who do understand that, as well as then work to address the gap. And that's where your Plan, Do, Study, Act, or your PDSA cycle comes in. So I have to say that the first time that I got taught this, and about the fourth time I got taught this, I still couldn't quite understand it. So I'm going to try to simplify it, but again, we'll send out these slides. So the first thing that you've done is you've already identified the gap. We're going to work on, secondary contact. We're going to work on, we talked about people showing up for scheduled appointments. So the first thing that you need to do is to understand why the gap exists. So that's your response to the identified gap. To make a plan to do the gap, decide how to implement it, who's responsible, what, when, and where, and then you're going to do it. So you generally don't want to do this across the entire clinic. You want to do this as a small scale. So for the next week, for the next 2 weeks, for the next 10 clients, you want to document the problems and begin this sort of light touch analysis. And again, where we use things like run charts. Now, the study is not doing research on it. It's actually looking at your initial measurement and said, did the measurement show the expected difference? So again, we talked about the percentage of people who attended scheduled visits. And if it started at 10%, did it go up a bit? So in the next 20 patients, did we still only have 2 patients who came back, or do we actually have 5, or are we at 10? Were there other changes that were seen? You're sharing that back with the QI team, and then you decide what your act is. So if it looks great and it seems to be really working, then you might want to continue it. If you hit, you really just got it perfect, you might want to expand it and integrate. Remember whack-a-mole, so you want to integrate what your changes are. Or do you actually have to go back in and say, maybe we addressed one problem, but not all the problems. Maybe we didn't address the right problems. This idea about other changes seen is really, really important. I do a lot of global health work, and I was working in a country that was had a huge HIV burden, and they just started getting access to treatment. And you're supposed to examine people for clinical symptoms each time that they came in. And it wasn't happening, and we did a whole QI project, we educated, and within a week, people hated it. And the reason was because instead of people having 5 or 10 minutes, which is what they needed to do to see 100 patients in the day, all of a sudden it was taking them 20 minutes per patient, and the patients were never being seen. And so we had to figure out how to do some task shifting. So again, you want to measure not just did you get the change that you wanted, but did you sometimes get some changes that you didn't actually want. So how do you understand why the gap exists? So there's a couple of key tools that you can use. And again, we can send some links to much more in-depth trainings on this, but a flow chart, which is what is supposed to be happening. And that's a fascinating experience when you get people in a room and you realize that 6 people have 6 different viewpoints on what's supposed to be happening. Something called a root cause, or fishbone, or Ishikawa, which sort of lumps into possible causes. And then sort of what are you going to do about it? And brainstorming and teamwork, again, is critical. This isn't one person's job. Again, a flow chart is mapped at what should happen. It's sometimes pretty detailed steps. Again, don't let this take you 3 months to do that. But again, for example, if the client's coming in for housing, you want to start with them needing housing and go from there. And what is there? It's this very sort of client-centered. What is their process that they need to actually do it? So putting yourself in their shoes. This is an example of one that has to do with prevention of mother-to-child transmission. And again, taking the woman who comes in, this is going into a regular OB clinic. They check if the HIV positive status is documented. If it's documented and they're positive, they get appropriate PMTC and then they're started. If it's negative, they get tested. If they're HIV positive, they go back in. And if not, then they go back to routine antenatal care and they get retested at the 3rd trimester. Obviously very simple, but it tells you where this may be, where a system may be falling apart about why women may not be started on PMTCT. People may not document it, they may not be testing, they may not know what appropriate treatment is, etc. Oh, hang on one. Oh.
The next thing is, sorry, my headphones just died on me, is the brainstorming the gaps. So you might refer to the flow chart as a guide, and for each of the steps, you would list the possible causes of a quality gap. It's often good to have a team to sit in the space and continue until you've exhausted all the ideas. No idea is a dumb idea. They're all interesting ideas. And then you want to sort of group them into different groups of where you might address them, whether it's human resources or patient factors, guidelines, infrastructure, where you might want to actually do that. And then this is an example for too few mental health screenings. So it could be that nobody's trained. It's not clear whose job it is. Maybe there's no place to document that it's actually been done. Data quality gap. There's no referral options. Screening is done separate from the regular care, so patients have to visit, so they leave. So that's a systems thing. Patients are resistant to getting screened. Maybe there's some stigma around it. And that's just sort of very, very quick. What are some of the issues that you might see along the flow chart for mental health screening? This is what an Ishikawa diagram, root cause or fishbone looks like. And so again, you would, often I do this on like a flip chart. This is back in the good old days when we were all sitting in the same room. Now it's probably more screen share using some sort of documentation about where the different challenges may be that contribute ultimately to the gap. And then that will help you decide, in the same way you prioritize the big gap, prioritizing which of these potential areas you're going to address. So this, again, is low rates of mental health screening. So again, the screening guidelines might not be clear. The charts are not well organized. Resources, there might not be enough mental health resources. People don't bother screening because what am I going to do with that information? There might not be enough space for that to actually be done confidentially. The staff may not be too trained, may not be too few or not trained. You might have nurses do it who get called away to do other things. So if what's up patients, maybe they come late to appointments. They don't want anybody to know about mental health. They live too far away for follow-up, so they're not interested. Or again, issues around community stigma. So that's just a very quick approach of what something like this might work, and why also you need to have, therefore, remember that team, that was the fourth question. This is what that quality improvement project team would be doing. So designing the first do. So the first thing is, again, which we've already had a great example of, is there something easy that another program has already done? There's very few challenges that any program will have that probably hasn't been encountered by another program. And the first thing often is looking around and asking. And when I've been involved in consortium, in groups of programs, often we look for somebody who what we call is a positive outlier. Somebody who actually has really good attendance. Somebody who actually has like 90% mental health screening. And instead of always focusing on the people that have the low rates, go to the high rates and say, tell me how you're doing this. Like, help me learn so we can teach other people. Again, this idea about, is there a change package or a bundle available? And these do exist, and they're a little bit harder to find, and we'll keep on looking for those but there's definitely a lot of ideas people have done, whether it's about adherence or loss to follow-up or other things. Start off relatively smaller and simple. So what can you change by next week? Test it out. You know, again, maybe we'll do it on the first 5 patients and we'll see if this seems to be working or not. Again, this is qualitative. Is it working or not? If it takes you 6 months to design your first intervention, it's probably a little bit too long. And again, you need to sort of figure out, how do we do this in a way that allows you to try something and test it. And if it doesn't work, you haven't invested 6 months into it. Make sure all the stakeholders know what you're planning and why. So if, for example, you're doing something about return to care, and you know that the person at the front desk is going to be impacted by it, and if you don't let them know what's happening and ideally have them on the team, often people will be very resistant to actually making any changes. And then it's very important to document what happens, both the good and the bad. So again, is there routine data available, like from REDCap? Can you do this mini chart review? And again, this idea about really noting any effects on resources or other systems. So again, going back to the mental health screening, if we fix that problem, 100% of people get screened for mental health, but we still have no difference in the resources available for people who need mental health issues, you're going to end up with both providers as well as with clients who are not going to be very happy, because you've asked, you've identified a problem, and you don't have the next solution. Now, often, again, you may need more than one solution. This is something that's called a driver diagram. Again, another tool that we often use. And so the gap here is, again, that, that only 25% of people are being screened. You've done some sort of digging and you think there's your core causes are that nobody is doing the screening, that patients are refusing the screening when it's being offered, and the screening is done but not documented. So again, we have two that are quality of care, and one, the last one, is a data quality. So, excuse me, you may need to actually have a number of different solutions. So if nobody is routinely doing screening, you might need to change the workflow, train the staff. They may again be not doing it because they don't have any referral options. Again, you may need to educate the patients. You may need to do community outreach. Sorry, that arrow didn't work very well. And then the screening, you might want to identify how to document it and where. And so you can see there's a lot of different people who might be involved in this, but probably unless you do all three of those, it's going to be a little bit harder to get up. It's actually the percentage of documented screening that is done. So again, distinction between screening that is done and documented screening that is done, because you need to deal with that last problem. So then you work to address the gap. Again, it's screening. You create a team to improve the workflow to ensure that all the patients receive mental health screening. So then you do it, you carry it out, you document it, and you begin to take a look at the analyses. Again, did your repeat measurements show expected difference? Did it go from 25% up to 50%? Again, were there other changes that were seen? And again, very, very important to share back with the team. Celebrate success. We use something called the sandwich. If nothing's happened, it's like, I'm so excited that you are all involved in doing quality improvement. Sadly, we didn't see any change. So let's work together to, to continue. So you have some positive, sometimes the not so good information, and then sandwiching it with positive again. So the first workflow is tested for 3 days. It slows some things down, and only 60% are screened and only 40% are documented. So a little bit better, but some challenges here about slowing things down, still not getting up too high, and you still have a data quality gap, right? 60% screened, 40% documented. So adapting the intervention and trying it again. So you probably wouldn't give it up because you are seeing some positive things. And then you say, did it work? Will you expand and sustain it and teach other people? And if not, what would you try next? So 2 months later, 80% are getting screened, 100% of the screens are documented, and now you're moving on to referrals. So what happens if nobody wants to listen? So you will encounter resistance to change, even if people understand the importance of quality. And this took me quite a few years to kind of come to terms with this, because I kept thinking, well, if I show people enough charts, I show people enough data, they will change. And the answer is no, and that's because, you really need to understand, in the same way we do a root cause analysis for the quality problem, we have to understand why is there resistance to change. So the issue is, sort of why is it hard? And so you really sort of have these two big buckets, one of which are the drivers to change, and the other is the resistors or the barriers. So it could be individual, could be structural. And you have this constant tension between the two of these to see whether or not you're actually going to see change. So this is an image that I like to use. So do we think this gentleman is going to be able to move the elephant? Any thoughts? We think yes? He must be very strong. Doesn't look too strong to me.
We're getting some no's in the chat.
There we go. No, very unlikely. So the question is, what can you do? And so the answer is you can add some drivers. So maybe you actually have more people who are actually working together, team, to actually change improvement, and they're able to sort of gather more people. But you can also incentivize. So we've done things like, a free lunch for the first clinic that has perfect data quality. And I've actually done this. So one of the things you can do to incentivize, usually it's not financial, but it could be things like prizes or recognition or other ways of sort of incentivizing change. And sometimes actually there's ways of incentivizing things through system change. So for example, telemedicine switch was actually quite challenging But one of the big changes that actually pushed it through is the fact that insurance companies were willing to reimburse equally. And that's a pretty big bale of straw or peanuts, depending on which images I'm using, to get systems to actually make change. But you can also decrease the resistance. So do people see what I've done here? We've put them onto roller skates. And so the idea is that you want to both incentivize people, but also understand and address why they are resisting. Or often you do both. And there's some systems that we can use, and this actually comes originally from marketing, because if marketing knows nothing better, nothing else, they know how to make us change our behavior to like buy some things or to want to do something different. And the idea is that sort of three main ways in which people are why change is not happening. The first is the opportunity environment. If you do not have enough staff to do screening, it's just not going to happen, because people don't have the opportunity to do that. The environment doesn't help. In places where I'm working for hypertension, for example, in some of the clinics in Nigeria, if you don't have a blood pressure cuff, you can't actually get people to take blood pressure. And you can train from now until sunset, they're not going to be able to take the blood pressure. The second is the ability, or cognitive. So have you given people the skills to actually be able to do the kind of screening? And so, for example, if you haven't trained people to do the mental health screening, or to use the telemedicine, or to figure out how to actually collect that secondary follow-up, they're not going to be able to do it. And so you have to not just do that opportunity, but you need to train people to do it. But now it turns out that sometimes, even if you give people the environment and you train them, they're still not doing it. And that's probably the one that's, for me, is the most challenging, but also the most inspiring, which is motivation and beliefs. I don't believe that that mental health screening is actually worthwhile. I don't think this is all we need to do is get people virally suppressed. You may train people to screen, you might give them the opportunity, they are not going to screen until you actually understand and get them motivated to actually make the change that you actually want to have happening. And you really do need to talk to people and understand why is it that people aren't doing things. And I'll tell you one small story about this. I worked with this big thing called the Better Birth Program, which was looking to see if we can improve maternal care. And this was in Uttar Pradesh in India. And we could not get one of the nurses to take temperature. And it's very important to do that for women who are in labor. And first she said, I don't have a thermometer. The thermometer gets locked away. So, okay, fine. So we're going to address the opportunity barrier. And we got a thermometer. And then she said, no, I don't need to do it. I can tell when women have a fever, when they have an infection, which of course is not actually true. And we spent a while talking to her about that. And she was an older woman. And like me, has slightly aging eyes. And it turned out actually that it had to do with the ability that she couldn't see the thermometer. But she didn't want to admit it. So we actually got her reading glasses, and that actually solved the problem. So you have to really understand, why is it that individuals or systems are resisting your change? And that goes back to this idea of how we actually design and test, and also are willing to do PDSA cycles of how we're actually working. So again, what predicts acceptance or resistance? It's your method of introducing the change, communication, engagement with stakeholders. Do you have the leader who says this has to get done and we're going to make sure it gets done? What are some of the individual factors of the person who you want to change, but also the group and the organizational factors? And again, this is where coaches and leaders can help. If you don't have the leader of your program, of your project, who's saying this is important, it's often difficult to get people to do things. All right. So, again, engaging people in the change. People do not resist change, they resist being changed. Any of you who have children or partners, or for me, parents who don't change, who don't want to change, they resist being changed. So often you have to ask their opinion, get them on board, ask them what do they hope will happen, but also what do they fear. Sometimes when you're changing the responsibility of something from one person to the other, you would expect the person whose responsibility that is no longer their task, that they might actually be happy about it, but they may fear, what does this have to do with my position, my authority, my reputation? What suggestions do they have? And then provide a clear picture of the future and answer questions. What will the workflow look like? So if we're going to integrate mental health screening, who's going to be doing that? What will it look like? What do people think? And provide opportunities for that kind of feedback. So again, it's this idea of stakeholder engagement that really is important. Make sure they understand what you're talking about. So the information as presented, is it too complex to understand? You've been living and breathing this for the last 2 months. Can you explain it to people in a way they do it? Understand the history behind the problem. So did it end up in this way, which isn't working by design, by chance, or was it someone's individual decision? Is there somebody sitting in the audience, this was their pet project to design it the way it is now? You're saying it's not working, it needs to move over. You need to understand why it is that, and have people try to make this change before and had it fail. Get management leadership buy-in, and describe what are the first steps. So again, this idea about getting people, what's it, developing a plan, and who will be responsible, who will be involved and affected. Understand what new knowledge and training is needed, and very importantly, what resources are needed. So a lot of times people's answer is just training, and that can be a very, very important part of it, but often it's something more than that. So in summary, with quality improvement, the first step is that we need to know what is our goal, so guidelines and standards. We measure, and we see the actual performance there, and so that's our first performance gap. Then we do the quality improvement intervention. We see some change. We measure again, and there's a performance gap. So then we do a second intervention. And actually we get very close, or close enough to our goal to be able to go. And that's really, I think, the goal of what we want to see people beginning to actually do. And then you celebrate. Very important to celebrate.